welcome everybody. My name is Liadh Fitzgerald and I'm absolutely delighted to welcome you to my IVF Answers with European Fertility Society. We're here with Dr. Karpouzis from Pelargos IVF. So we're going to have a wonderful presentation today. And it is all about recurrent pregnancy loss challenges. We're going to have a fabulous presentation and time for Q&A at the very, very end of it. So just a couple of bits about housekeeping. This presentation is, of course, going to be recorded, okay? For anybody who might miss some of it, you can catch the recording tomorrow. They go up a day after the live event, and you can get that at myivfanswers.com or on the My IVF Answers YouTube channel. So please make sure to have another look at it if you would like. Just to let you know as well that everybody's name is, you're totally anonymous on this platform. So your name will not come up even if you ask a question. Talking of questions, if you would like to ask some questions to Dr. Karpouzis, please do put them into chat. The invitation is there for you. As the presentation is going on, I will be in the background actually, going through the questions and looking at them. And there will be an opportunity at the very, very end for the majority, we hope, of questions to be answered. Often there are quite a lot of questions, and in that instance, we would invite you to forward your questions either to My IVF Answers or to Dr. Karpouzis and his team, and then from there, they will come back to you with answers. So for now, Dr. Karpouzis, thank you very, very much. I'm so looking forward to this presentation. I'm going to share your slides, and I hope everybody enjoys the presentation. Thank you.
Thanks, Liadh, and hello to everybody. I'm Harry Karpouzis. I'm the scientific director of Pelargos IVF. We are a fertility clinic based in Athens, in Greece. And we will talk today about recurrent miscarriages, recurrent pregnancy loss. And we will present in the end some quite interesting real cases and success stories that we had in the past with recurrent miscarriages. I will pass a bit quickly the first slides so that we can stay in the most important ones, which are the real cases. But as a prologue, the definition of recurrent miscarriages, according to the American Society, the most recent definition is 2 or more consecutive failed clinical pregnancies, which means pregnancies documented by ultrasound or histology, of course, if someone has a DNC. 15 to 20% of the pregnancies generally concludes into miscarriage. Of course, this percentage goes much higher after 40s. And the statistics behind recurrent miscarriages in the rate of about 1%. But given of the number of the total miscarriages, we understand that this is something that has to do with many people, and it is a very difficult situation as well, and very, very traumatic for most of the people that are having recurrent miscarriages. So what tests, what weapons do we have to investigate about recurrent miscarriages? Lots of things. I have a list here of all these tests, and some of them might be known to you, like the hysteroscopy, like the karyotyping, like the laparoscopy, and some of them have to do with tests not very well known, like, for example, the immunology testing, like the thrombophilia testing, the DNA fragmentation, and we will have the chance to talk later about all this. The causes of recurrent miscarriages. In 50% of the cases, in some statistics even more than that, chromosomes play a role. So the problem is in the embryo, is in the chromosomes that are inside the embryo, and this is the most common reason of miscarriages. And this is why it is more common in women more than 40 years old, because in this age, the chromosome abnormalities are more prominent. We can have sometimes genetic association. It can be combined, associated with genes, and there are specific tests for that. Very often they are associated with uterine abnormalities, like, for example, intrauterine septums, adhesions, fibroids, polyps, Many times thyroid and PCOS play a role. Immunology, natural killer cells, antiphospholipid syndrome, lupus might affect and cause recurrent miscarriages. Endometriosis can be associated in a degree. Of course, infections like the famous chronic endometritis and other infections like SEMV, toxoplasma, oroplasma, herpes can be associated with all this. And of course, lifestyle like smoking, like obesity, that is considered to increase the rate of miscarriages to about 1.5 times more. Alcohol. Let's start very quickly one by one. With PCOS, we have hormonal imbalances. It's a metabolic syndrome that has to do with increased androgen. It has to do with insulin resistance. And actually, PCOS causes a chronic inflammation and ovulatory issues. And these are the main mechanisms behind which they can cause miscarriages. We have noticed that in PCOS, in polycystic ovaries, the risk increases to about 30 to 50% in comparison to a woman that doesn't have PCOS. Metformin, glucophage, is a medication that is supposed to help in reducing the risk, and inositol as well. Endometriosis is a very well-known condition that is associated with painful periods and painful sex sometimes, but it can give other symptoms as well. It can be associated with subfertility. This is something that we know, but it has a mild association with miscarriages as well. And the reason is because endometriosis very often is associated with immunological problems. It is associated with a chronic inflammation, which can cause miscarriages. And the more severe the endometriosis, the more the risk of a miscarriage. Thrombophilia is the blood clotting disorders. Not all the thrombophilias cause recurrent miscarriages. There are some of them and specific ones that are strongly associated with this, like the factor V-Leiden, and of course, if it is homozygous mainly, not heterozygous, and the MTHFR when it is homozygous as well. The thrombophilia, the blood clotting, can cause problems in the placenta. It can cause abnormal blood vessel development in the placenta in the early stages sometimes as well. And of course, thrombophilia needs to be investigated by hematologists as well. At Pelargos IVF, we have one in the team. And many times the solution is anti-clotting injections and aspirin. Antiphospholipid syndrome is a very specific thrombophilia, which causes increased risk of clotting, but also is an immunological disorder. And it's very important to determine what is APS. It's very crucial to have the right definition of APS. APS, when it is associated with miscarriages, we need to have 3 miscarriages in the first trimester or 1 late miscarriage to investigate about antiphospholipid syndrome, because it is very often associated with late miscarriages as well. It interferes with the implantation. It causes some antibodies through the immunological system that can cause miscarriages. And the solution about it is, if we identify it, to treat it with injections, to treat it with aspirin, to treat it with steroids, or sometimes even medication like Placanil. Thyroid is associated as well. Women that have increased anti-TPO antibodies, which is the Hashimoto disease, needed to bring down the TSH less than 2.5. Thyroid can cause miscarriages. It is not clearly associated to recurrent miscarriages, but it can contribute as an adjuvant factor or as the sole factor in miscarriages, and that's why it needs to be very well controlled. Very important factor that many times we forget when we deal with recurrent miscarriages: sperm. It's not only the woman, it's the sperm factor. The sperm factor plays a role in about 50% of the cases. And it's not only the sperm analysis. When we have recurrent miscarriages, we need to investigate about DNA fragmentation. We need to investigate about oxidation as well. And what we can do about it, okay, one solution when we have increased oxidation and DNA fragmentation is antioxidants, of course, but nowadays we have some sperm selection techniques that have some good data behind it, that has to do with MAX enzymot, which are sperm selection techniques that can also actually select the sperm without the oxidation, without the DNA fragmentation, and put this sperm inside the egg, so that we can improve a bit the blastulation rate, and we can improve the chromosomes inside the embryo as well, to give better results. Many times we forget about the oxidation and we treat only the DNA fragmentation, but you need to know here that sometimes the DNA fragmentation is not always associated with oxidation. Sometimes we might have DNA fragmentation and not to have oxidation. And, if you don't check both of these factors, in many cases, doctors sometimes give antioxidants without really knowing that oxidation is the problem. And this might make things worse rather than better. So it is important to check both of these factors so that we can improve the sperm before we inject it inside the egg. Uterine abnormalities, the golden standard for that is a hysteroscopy. It's a camera inside. And what we are looking about fibroids. We are looking about submucosal fibroids especially that are inside the endometrium, or polyps that need to be removed irrespectively of the size. And sometimes when we have fibroids that are outside the cavity, this is a different thing. It depends if we need to remove them or not, and the evidence is quite conflicting over there. So we always personalize when we need to remove a fibroid that it is not inside the cavity. But when it is inside, or we have a polyp inside or a septum inside, all these things need to be removed, and we need to investigate about it because they can cause miscarriages. Hydrosalpinx is when we have fluid inside the tube from infections, from endometriosis, from past surgery. Sometimes this fluid can be toxic and can cause miscarriages. We need to identify that with a scan. If we have difficulties with a high COSI or an HSG, and we need to treat it, and we need to block the tubes so that the fluid doesn't go inside the cavity and doesn't cause miscarriages. Endometritis is a chronic infection. And what's the golden standard actually of endometritis? We cannot always identify endometritis with cultures from the vagina. We need to have a hysteroscopy to see inside the cavity. We need to know what we need to see because, doctors that are not reproductive medicine minimal surgeons many times are losing the science of hysteroscopy. It's not easy sometimes as well. We need to take targeted biopsies sometimes from the lesions that we think are associated with infection. And if we have an infection, we need to treat it with antibiotics. And this might improve and give the solution. About infections, the main infections that are associated with is uroplasma, mycoplasma that needs to be treated, but other infections can cause as well a miscarriage. So when we have an unexplained miscarriage and it happens during pregnancy, it is a good thing to check to see if it is associated with a temporary infection as well, because sometimes it is just an unlucky event that someone is having SEMV or toxoplasma in the early pregnancy, and this is what is causing the miscarriage. And this doesn't mean that in the next pregnancy we'll have the same. Let's go to immunology, which is a very conflicting issue, a very difficult issue. Different opinions about that. We deal with immunology. We appreciate the science of immunology behind miscarriages and subfertility. It's a whole mechanism for an embryo to implant. And when you know exactly the mechanism, you can see that there are many factors that can affect the implantation. Or if the embryo is implanted, it can affect the development of the embryo. You will hear many different names like uterine natural killer cells, TH1 to TH2 ratio, T regulatory cells. All these cells maintain a balance inside. And if you have overactivity or underactivity, you need to know it so that you can treat it. We don't treat and we don't investigate all the people about immunology. We need to have a history of recurrent miscarriages in order to investigate, because these are more rare conditions. We use a test which is called IMAP that has to do with the natural killer cells inside the endometrium, because at Pelargos IVF, we believe that what is happening in the blood does not always correspond to what is happening locally. And also, even the hormones that someone takes might affect the local immunology of the endometrium and might play a role in the implantation or in miscarriage. I will not go in detail with all these names and tests here, but what I try to make you understand here is that when someone takes estrogen, progesterone, every single medication can affect the local immunology at the time of the implantation window. So when we know and we take a biopsy of what is happening over there, we can see if the profile is over-suppressive or under-suppressive. And, I have noticed many times that we say, okay, we have a miscarriage, let's give steroids. If it is an under-suppressive environment and we give steroids, this might make things worse rather than better. The solution is in personalization, and we need to know exactly what is happening over there in order to treat it and to give the right treatment. There are many medications like steroids in a dose of usually 20 milligrams, intralipids, IVIG. All this medication play a role when the environment is over-suppressive. So when the immunology of the body attacks the embryo and they try to reduce the population of the cells over there, to decrease the interleukin 15, to make the ratio of Th1 to Th2 towards Th2 rather than Th1, to reduce the natural killer cytotoxicity. This is the role of this medication. Anti-clotting injections are immunomodulators as well. They change the immunology, and sometimes they can be used as an adjuvant treatment in immunology. Intralipids, in case it is needed. Even the doses of progesterone, if you will go high on progesterone or low on progesterone, if you target personalized in the immunology, you know what will be the personalized protocol in the next attempt. Many times, we find out from these tests that the problem is not over-suppressive. It's the opposite. It's under-suppressive. We don't have a lot of mobilization of natural killer cells that can be important for the implantation and the development of the embryos. And in cases like that, we know that we need to give more luteal support. And medication like Ovitrel before and after the embryo transfer can play a role on that when you know what exactly is happening at the time of the embryo transfer. PGTA. When we talk about recurrent miscarriages, we talk about PGTA. When someone is having 3 or more miscarriages, 2 or more miscarriages, 1 late miscarriage and 1 early miscarriage, IVF by itself does not give the solution, because you can transfer an embryo, you can treat all the other things that are more rare, but the most common reason is chromosomes, as we said. So if you keep transferring embryos that you don't know what they have inside, you will not know the reason of why you have a miscarriage. When we are talking about PGTA, we are talking about frozen cycles. It can give you a result. It can give you a result of euploid embryos, aneuploid embryos, and mosaic embryos. Even if it gives you a result of mosaic embryos, you will know if these are transferable embryos or not. And before we transfer an embryo after recurrent miscarriages, when someone is doing IVF and when we reach the stage of IVF, we need to do PGTA as well. Yes, PGTA is not always accurate, but when there is a geneticist to explain the results, the patient knows exactly what to do. And the whole thing with PGTA is in the documentation and in the consultation to the patient on when he can transfer an embryo and when not, and with what chances. PGTSR, it's a variation of PGTA, and it is used when someone has translocations. The translocations can be either reciprocal or Robertsonian. All these are balanced translocations, and someone might be completely healthy and doesn't know that has translocations. And that's why when we have recurrent miscarriages, we need to check the karyotype of both the man and the woman. And if we identify translocations, then PGTSR can give the solution and can check the embryos, the healthy embryos, to put back. The transfer and how we will do the transfer. If the transfer will be done with down regulation when we have endometriosis, if it will be done on a natural cycle, semi-natural cycle, or estrogen and progesterone, all these have a physiology behind, and in every case we need to personalize. Let's go to the cases now. The first case, patient from Malta, 35 years old. She had 3 spontaneous miscarriages. which means that she got pregnant and she miscarried 3 times. In the third miscarriage, she sent the products of conception for a chromosome analysis, and she found out that the embryo was euploid, and it was a male euploid. And I write that because many times in early miscarriages, when you send karyotype and the DNC is not done correctly, or it takes maternal tissue as well, the result might come back as female. And many times we have seen that it's actually female tissue rather than the tissue of the embryo. So this male euploid embryo tells us actually that the embryo had normal chromosomes. So this is an important information to get from the beginning. So we check other things, and we check thrombophilia, and that was normal. The patient didn't have any immunology testing before. She had done though a hysteroscopy, and it was clear, but no biopsy was taken. So the clear of the hysteroscopy can be a bit conflicting and not always very accurate. She had laparoscopy in the past as well, and we didn't see any signs of endometriosis. And she had a history of PCOS with a very good AMH of 4.2. We went to IVF. We proposed, of course, PGTA. We started here on a short agonist protocol with a high initial dose, which we stepped down. At Pelargos IVF, we always have a personalized approach that we measure the LH and estradiol and the follicular growth in every single ultrasound, and we alterate the doses. We got a very good number of eggs, 22, 19 were mature, which for PCOS, it's a very good result. We checked the sperm. We didn't forget about the sperma, and we found out that the oxidation was 2.5, which is increased. We used Zymo, the sperm selection technique. 12 of them got fertilized, and we had 6 that went to blastocysts. Before we froze them, we did the PGTA, and 3 of them actually came back as euploid with good gradings. And then we need to decide the protocol to put them back. And the protocol to put them back, we need to do some investigations because we had a miscarriage with a normal embryo before. We did a repeat hysteroscopy, and we've taken some biopsies this time. It didn't show any infection indeed, but it showed the microbiome deranged, so we proposed probiotics to this patient. We've done the IMAP test, the immunology testing, and we found immunological disorders, an overactive system with raised natural killer cells and with raised ratio of Th1 to Th2. So we proposed a protocol for her with probiotics, with Placanil, with steroids, and with glucophage, metformin, which is because of her polycystic ovaries. We've done the transfer on a hormonal replacement treatment with estrogen and progesterone. We checked the progesterone levels. We always do it before the embryo transfer. And we had positive beta HCGs and a live birth on a male baby. Very lovely baby. Second case from Ireland, actually. 42 years old, advanced age. She had 1 child born with a normal delivery in 37 from a spontaneous conception. 5 years later, she was keep trying, and she had 2 miscarriages, spontaneous miscarriages, and 1 failed IVF. It didn't even implant on the first attempt, which was, I think, a fresh transfer. Then she had a frozen transfer in the previous unit. She got pregnant, but she miscarried again. She had from her history a mild history of endometriosis. She had polycystic ovaries as well in the past, an AMH of 2.1 that for 42 is a good AMH. And she had done a hysteroscopy, which was clear. We suggested again IVF and PGTA. We checked the sperm for DNA fragmentation, which was not checked before, and we identified DNA fragmentation of 28% and raised oxidation of 3.2. He had also a mild varicocele, so it's quite common when the male partner has a varicocele to have increased DNA fragmentation. We proposed antioxidants on him. We started here on a short agonist protocol with a high initial dose. We are not afraid of high doses in polycystic ovaries because we always freeze. We retrieved 15 eggs. We got 14 of them mature, which was quite impressive. 8 of them fertilized, 4 blastocysts. We've done PGTA, and 1 of them with a grading of 3A8 day 5, it came back as normal. You understand that this is a very precious embryo. So we need to do all the checks before we put it back. We cannot compromise it. It's not easy to get it. We don't know if we will get it again. So We repeated with an IMAP test, which is the immunology test, after we have done endometrial preparation, estrogen and progesterone, and then the test. We've done the hysteroscopy, we've done endometritis test. Chronic infection was identified. We treated the patient for herpes and uroplasma. The IMAP test showed the opposite from the previous case, a low mobilization of natural killer cells. So we understand that in a case like that, we know what is happening and we cannot give steroids because it's the opposite problem. We gave, though, we started the protocol of the frozen transfer with a GnRH analog with a gonapeptyl downregulation to cover the endometriosis as well, because we know that this patient had endometriosis. We gave her glucophage because she had polycystic ovaries, and we supported the pregnancy with ovitral injections before and after the embryo transfer. We got a positive beta HCG, and she had a live birth at 36 weeks with a cesarean section. Third and last case, and then we will go to the questions. Patient from the UK, 39 years old, one late miscarriage, spontaneous miscarriage before, it was late miscarriage, so she was investigated about adiphospholipid syndrome, and it was right that she was investigated, and she came back positive. She had the true definition of adiphospholipid syndrome, because many times we name a person adiphospholipid syndrome, but they are not actually. In the next pregnancy, she took Clexana and aspirin, and she miscarried again. Then she had IVF in the UK. She did PGTA. She got one euploid embryo. She transferred on a cycle with hormonal replacement treatment at the clotting coverage, and she had a negative test. It didn't even implant. Her AMH 2.6, good for 39. We advised, she came to us to do another cycle of IVF. Of course, we advised PGTA. We've put her again on a short antagonist protocol with our personalized approach. We checked the sperm about the DNA fragmentation, and it was clear. We got 9 eggs from her, 8 of them mature, a very good maturity rate. All of them fertilized with ICSI, which was very good. And in the end, she managed to have 4 blastocysts. 2 of them in the PGTA came back as normal. One of them 5AA grading, the other one 5AB, 4AB. And then we need to decide what to do before we transfer. So we proposed the hysteroscopy, we proposed the immunology testing, we proposed the endometrium test, which is like Alice Emma tests. It's a test that shows about chronic infections. That came back normal. The immunology test came back normal. The hysteroscopy was normal. No suspicion of endometriosis. We did the transfer. We transferred with prednisolone because of her APS, which is an additional treatment, Clexan, aspirin, and she had a biochemical pregnancy, which is completely unexplained. And then we decided to check about HLA and KIR tests, which came back as positive. This is incompatibility, actually. There is no positive, it's incompatibility. The sperm sometimes can have some antigens, which is HLA-C, and the natural killer cells of the woman might have some antibodies, which are called KIR-AA. And when we have this incompatibility, it can be associated sometimes on miscarriages. We decided to transfer on a natural cycle this time because she got pregnant before spontaneously. She didn't get pregnant on HRTs. She had a biochemical pregnancy, so we tried to go on her natural ovulation. We covered her with anti-clottings, we covered her with steroids, and we gave a medication which is called GCSF, Neupogen, which we usually give when we have HLA incompatibility. We used acupuncture as an adjuvant as well, and we did the transfer, and she had a positive test finally after all this. She gave a birth at 39 weeks with a cesarean section, and she has a healthy baby right now. As a conclusion and as an epilogue, very important to go deeply through the medical history. If we don't go deeply, we lose things. A very detailed history. We need to analyze the history of the previous miscarriages. We need to know all the information and have detailed data about everything. And we need to check 4 things: the embryo, the uterus, the womb, the sperm, and the body. We need to do PGTA, otherwise we will not know what the issue is. We will keep transferring, it might work, but if it doesn't work, I will go back to you and tell you, listen, we don't know what was inside the embryo. So we always do PGTA in recurrent miscarriages. We investigate thoroughly before the transfer about all the other factors. We choose the right protocol of transfer, and it's a right protocol of transfer for everybody depending on the case. We think positive and we make it happen.
Amazing. Thank you so much. That was absolutely wonderful. I was glued to every word, and I know the listeners are as well. We have a list of questions. And again, I would invite everybody to pop any questions you have into that chat box, and we'll try our very best to get to them. So I'm going to share the first one with you, Dr. Karpouzis, because I want you to be able to read it. It's quite a long one. So I'm going to display it for everybody. So I understand that for healthcare workers, pregnant healthcare workers shouldn't handle patients with CMV. What if a patient who was a CMV positive was handled? Does exposure to sick CMV patients, can that cause miscarriage? This individual had miscarriages at 5 weeks after handling a CMV positive patient, and after 2 months got pregnant and no heartbeat at 9.5 weeks. If positive for CMV, would it affect future pregnancies? And thank you for that question.
Okay, listen, CMV is transmitted when someone is right now positive for CMV. CMV leaves immunity. If someone is CMV positive and has IgG antibodies positive, it doesn't mean that he has an infection right now. It means that has immunity. So these people do not transmit the infection. If someone has at that time CMV, yes, it can transmit the infection. And then you need to check yourself, because many people in the past might have CMV and they don't know it. So if we check yourself about CMV, you might find out that you had immunity of CMV in the past as well. So if you had immunity of CMV in the past, you cannot have CMV because you got in contact with a patient with CMV, even if that was a current infection. Now, if you are not immune to CMV and someone that you treat is CMV positive, then you might get the CMV. And if you get the CMV positive during the first trimester for the first time, and it's a new infection, then yes, this is associated both with miscarriages and with abnormalities in the baby. So this is something that when you have an infection, you can at that time check to see if you have CMV at that time. And if you have a CMV IgM test positive, it means that you have a current infection. So yes, it gives an answer, a possible answer on why you might have miscarried. Now, if someone has CMV right now, it doesn't mean that if he tries after 2 or 3 months, we'll have CMV again. We'll have immunity for CMV. The CMV IgM antibodies will be negative, and this will not be a problem in the next pregnancy.
Thank you. That's a great, I suppose, lovely answer. I'm going to display the next one that we have. And this is actually one that I have put up from somebody else. And you mentioned immune factors like natural killer cells and Th1 and Th2 profiles and reproductive immunology considered as an investigation after 3 early miscarriages or 1 late miscarriage. Is this a global standard approach? And if not, how would a patient know if immune testing is something that they should consider?
Okay, that's a very tricky question because immunology is very conflicting. There are people that believe in immunology, there are people that do not believe in immunology. There are very good studies behind immunology. There are randomized studies behind immunology, but there is not a consensus on what exactly is happening. We believe that some studies from Liadh French immunologists are very close to what is really happening in the implantation window. So when someone goes through a history of recurrent miscarriages, like 3 spontaneous miscarriages, we need to go through the history as well, because 3 miscarriages spontaneous in the age of 42 to 45, they are quite self-explanatory. The most common reason, like in 90% of the cases in ages like that, is the chromosomes. But let's say that you go for IVF and you find an embryo that is a chromosomically normal embryo in this age, for example. This is a very precious embryo, and immunology can affect a miscarriage. So before you transfer these embryos, in our protocols, at least at Pelargos IVF, because we believe in immunology, we want to check about it, because it would be very difficult to find an embryo like that again, and it's a very pity to transfer an embryo and miss something else. And also, it's a personalized approach. We don't like giving like steroids without really knowing that they will help. So we do the testing, we know what is happening, and then we treat according to that. So the answer is that yes, if someone has recurrent miscarriages, it would be good to check about immunology as well. If someone has one miscarriage or no miscarriages, of course, we don't put people into checking about immunology, because all these are very rare conditions.
Thank you. Wonderful. So I'm going to display one more. Here we go. So, and I have an extra little bit of information about this question as well. So 38-year-old with a history of 4 miscarriages, 2 missed miscarriages found at 12-week scans, 1 chemical, 1 at 7 weeks. Before doing their first frozen egg transfer, the main thing to check, what are the main things to check beforehand? And just in addition to this is that the first missed miscarriage was found to have trisomy 22.
Okay. Listen, because you are in a young, relatively age, 38, a trisomy 22 can happen, of course, in this age, and can be just an unlucky event. But definitely, I would check karyotype for both of you, because we need to find out if there are any chromosome abnormalities on you and your husband, like translocations, because this can increase the risk of chromosome abnormalities, confirmed chromosome abnormalities in the first pregnancies that you had. And then you had in total, I think, from your history, 3 miscarriages. So you drop into the category of recurrent miscarriages in an age less than 40. So first of all, if you go into IVF, and especially because you had the chromosome abnormality before, I would do a PGTA. Have you done a PGTA? I will first know if I have managed to create a chromosomically normal embryo before I put it back. So first, karyotyping for both of you, then IVF, then PGTA, find the healthy embryo, and then if you have this healthy embryo, I would definitely do a hysteroscopy to see that I'm not missing a chronic infection or anything else. And you discuss with your doctors if you want to go through more details, checking of immunology or anything like that. But it's not always a golden standard, the immunology. It's not for everybody. We start from the most common things, and then we narrow it down to the less common. And the first thing that you need to check is that the embryo that you will put back is a healthy embryo, and to make sure that at least we don't have anything missing inside the cavity, because ultrasound cannot identify everything, cannot identify a chronic infection, cannot identify the microbiome and other things. So these are the basic things that I would do for the beginning.
Thank you. If somebody has suffered repeated miscarriages due to embryo quality, at what age should one switch to donor eggs?
Sorry, Liadh, can I have the...
Of course,
yes,
absolutely.
okay. If someone has suffered repeated miscarriages due to embryo quality, at what age should one switch to donor eggs? It's a question that cannot be answered that simple. First of all, I need to know your age, how old you are. The quality of an embryo as quality, it does not always say what the embryo has inside. Many times we have seen an embryo of 4AA and we do a PGTA and it comes back as abnormal. And we see an embryo of that's my son. And we see an embryo of 4 BB, and we check the PGTA and we find out that the embryo is normal. So, I mean, if you are 42, 43, 44, things are very difficult to find a chromosomically normal embryo. And I don't know if you have checked if you are able to create a chromosomically normal embryo or not. So your age is very important to answer this question. Definitely in women more than 44, the treatment that gives the best results is egg donation, but egg donation is a very personal thing as well. You need to be psychologically ready to jump to this stage. And you need to extend, if you are not psychologically ready, your chances to get pregnant with your own eggs. You need to have consultation and clerking from the beginning about what are these chances, and then it's a personal decision on what you want to do. For example, I'm very honest in women that are 44 years old or 43 years old, that the chances are very low. You spend money and time going into a treatment that gives you low chances. If you are not ready to jump to egg donation, try it. They are not zero, okay, but you can try it. But you need to know exactly what is happening from the beginning.
Thank you. We have some wonderful questions coming in. We're going to have another few, if that's okay. What would be the possible reasons for miscarriage with PGTA tested good quality blastocyst after seeing baby with heartbeat at 6 weeks, but then silent miscarriage at 8 weeks growth?
Yeah, I mean, here we have a euploid embryo. So we know that the embryo that we put back is chromosomically normal. We have a fetal heart rate. And then after the fetal heart rate with a normal chromosome embryo, the chances of miscarriage drop to less than 5%, but we still have a miscarriage. So we need to investigate about other things. We need to investigate about immunology. We need to investigate about blood clotting, to take Clexane, to take aspirin. We need to do a hysteroscopy to see if there is any infection over there. These are things that we need to investigate because we have the information that we had a failed miscarriage. We had a miscarriage with a normal embryo.
Okay, thank you. So the next one. So dear doctor, thank you for this session. I'm 39 years old. I have stage 4 endometriosis. I had robotic laparoscopy to get rid of hydrosalpinx, and I got one euploid and one LLM mosaic del 7. I had a fully medicated cycle with estradiol, progesterone, and I became pregnant. Everything was looking great. Suddenly, in my second trimester, my cervix opened and I lost my previous pregnancy after 9 years of marriage. I did all kinds of tests on baby, but everything looked normal. I did another retrieval post my loss, but no euploids. Is it okay to do the LLM transfer? What are the things or approaches to keep in mind before transfer?
Okay. So just to understand, you got pregnant, but in the second trimester, you miscarried because your cervix opened. Yeah, that's the story, or that happened in a previous pregnancy. It's not very clear. I mean, let's take it one by one. First of all, it's a low mosaic embryo. You need genetic advice. It's a deletion, which gives good chances sometimes of, implantation, and lower chances of a baby with abnormalities. So I suspect, I'm not completely sure, but I suspect that if you talk with a genetician, will tell you that this is a transferable embryo with less chances though. If you don't have any other euploid embryo, you don't have anything to lose by transferring a low mosaic, but you need to know that this low mosaic has chances of miscarriage. But if you don't have any other embryo and you cannot achieve a euploid embryo and all the other embryos are aneuploid, it's your last chance. You can try it. Now, if the miscarriage happened because your cervix opened, this is a cervical incompetence. So we have a reason of why you miscarried. So you have a cervix that opens, and if your cervix opens, you need to have good obstetric management from the beginning of the pregnancy. You need to measure your cervix. You might need to put a stitch so that doesn't happen. And also, when a late miscarriage happens suddenly, and it is not a matter of the length of the cervix, this might happen because you were triggered with an infection at that time. So it might have been just an unlucky event. Because you got pregnant before, you had implantation and it kept increasing. So, I mean, either you try to achieve another euploid embryo, or if you don't want to go through the procedure, you transfer this embryo knowing, though, that it has higher chances of miscarriage after you have genetic advice by a genetician that will tell you exactly the risks by transferring an embryo like that. It gives you some chances, you can do it, and if you get pregnant, you need very good obstetric management from the beginning because of what happened in the previous pregnancy.
Thank you very much. So we have another question, and I will display this again as well, at least. So we're planning for a modified natural frozen embryo transfer with donor eggs, in which the protocol requires the use of a HCG trigger shot. I have high natural killer cells. Could the HCG shot impact my immune system, considering the high NK cells have levels in my body? Would you recommend a natural frozen embryo transfer in this case?
Not really, no. It will not affect the ovitrel. I mean, to choose, first of all, the natural killer cells, I don't know if you have done a test inside the uterus or if you have done a blood test. If you have done a blood test, it doesn't always correspond to what is really happening inside the uterus. And as I was saying before, I mean, if you have done it on a random stage of your cycle, it doesn't mean that you know what exactly is happening after estrogen and progesterone. So you just know that you have an overactivity in the blood, and you follow the protocol that your doctor will tell you in order to treat this overactivity with steroids or intralipids or whatever else your doctor will say. If you will do the transfer on a natural cycle or on a semi-natural cycle or anything else, it wouldn't play a big role on that. But I'm saying again that I mean, you don't know exactly what is happening in the immunology of your uterus after estrogen and progesterone, or after, the ovulation. If you were doing the natural killer cells with us, the protocol that we would choose for the embryo transfer would be the same protocol that we would have put you at the time of the immunology testing. So, if we pre-decided that we would do estrogen and then progesterone, 5 days of progesterone, we would have taken the biopsy after estrogen and 5 days of progesterone. We would know exactly what was happening over there, and we would follow the same protocol with the protocol that the tests would say to us at the time of the embryo transfer. And if we had decided to do an embryo transfer with ovitrel, we would have taken the tests after ovitrel. And then the same thing exactly, we would have done it at the time of your embryo transfer, so that we can mimic exactly what was happening at the tests at the time of your embryo transfer. But to debrief, in your case, since you have done these tests and you know that you have an overactivity, follow the protocol, and the ovitrel injection shouldn't play a role on the immunology. And you don't know what role would play, actually.
Wonderful, thank you. So for the lady who asked the question a while ago about the 3 miscarriages, and one had the trisomy 22, she's asking, Lappendie done 2 years ago, no abnormalities found. Should this be repeated before frozen embryo transfer?
Sorry, what was that there?
A Lappendie done 2 years ago showed that there were no abnormalities found. Should this Lappendie be repeated before frozen embryo transfer?
I wouldn't say. If you don't have a history that we investigate about something specific like endometriosis or anything else, there is no reason of doing a laparoscopy and eye test again. Laparoscopy is a surgical procedure since you have done it 2 years ago.
Wonderful, thank you. And just the final question to wrap up, for anybody who has experienced miscarriages, what are the top 3 things you think that they should be, I suppose, thinking about now, or maybe doing now before they try again?
For people that have recurrent miscarriages, you mean before?
Exactly, that they've experienced miscarriages before.
And they are trying for IVF now, you mean?
Exactly. So are there any things you feel that they should prioritize as they start again?
Well, first of all, every woman that, especially if she has a history like that, lifestyle modifications, avoid alcohol, avoid smoking. If we have obesity, reduce the weight as much as possible. Check about the thyroid and everything else, and make a nice plan about the next IVF. As I said, I would definitely check about the chromosomes of the embryo before I put it back, since the decision of IVF is made. And rule out any possibilities before we transfer the embryo, because recurrent miscarriages are very traumatic for everybody. Imagine that someone is getting pregnant, has the joy and the happiness of getting pregnant, and then miscarrying, and then again, and then again. So, I feel that this category of patients, psychologically as well, we shouldn't really be putting them into more failed attempts. We should check everything before we transfer an embryo.
Wonderful. Thank you so much. That was an absolutely phenomenal presentation, and those questions. Thank you, everybody who put a question forward, and thank you, Dr. Karpouzis, for answering all of those questions with such depth. So we're actually finished, and it has been an absolute pleasure. And for, as I say, just to repeat, for anybody who missed maybe some of this recording or would like to watch the answers again or watch the whole presentation again, it will be up on My IVF Answers and on the platform and on the YouTube channel within 24 hours, so tomorrow. So in the meantime, Dr. Karpouzis, thank you very, very much. It was a wonderful presentation, appreciated. And everybody, thank you for attending, and we will see you all again soon.
You're welcome.
Take care.
Yeah.
Thank you. Bye-bye. Bye.